First of all, thank you very much to Tatz, to Rabbi Mofson, for organizing this opportunity. As usual, Rabbi Mofson called me 2 days ago and he said, listen, my family situation, I can't arrange any talks, you got free time. Yesterday he called and he said, okay, Thursday you got 3 talks. So, that's how it goes. But it is a privilege to be able to do something in honor of his late father. We were very close. He was close to my father, who was a doctor. He used to actually identify novel medical things and show my father, encouraged me a lot. It was a very special relationship. The subject for tonight's talk is resuscitation and end-of-life care. So what I'd like to do, first of all, I'd like to just say a personal word about Tatz. It's an amazing organization. I mean, I see this all over the world. You have an amazing setup here. Just one example, I was in the car with Lawrence today, and he told me that the people were dispatched before the information was even gathered about what the problem was. They were on scene in 2 minutes. Right? So I don't think anybody can match that, That's amazing. So very privileged in the community to have an organization like that. And just a bit more broadly, South African doctors in general, I've lived in 4 continents, and there's just nothing like working with South Africans and South African doctors. Just doesn't get better than that. Many years ago, I applied for a training position in pediatrics in Denver. I went there for the interviews. They took a brief look at my academic stuff. They spoke to me for 5 minutes. You've got the job. I said, isn't it a bit more thorough than that? They said, no, you're South African. Right? And South Africans have made an incredible name in medicine across the world. And you see it, you feel it. You work with South African doctors. It's just such a special professionalism and a special care. They speak differently about the patients. They, just very privileged generation of medical training that went hand in hand with the whole Lithuanian values, and very, very great thing. You probably don't see it because you live within it, but when you look at it from outside, you see it's very unique. Let me try to digest for you the criteria that govern end-of-life care. Resuscitation, the way to handle that is to know what the principles are of end-of-life care, because resuscitation follows immediately from that. To put it in a nutshell, where you're required to treat a person in end-of-life situations, you're required to resuscitate. Where you're allowed to withdraw or obliged to withdraw care, you should not be resuscitating. So to know whether to resuscitate or not, you need to know what are the criteria governing end-of-life care. Moshe Feinstein writes that where you have certain criteria that mandate stopping treatment, it is wrong to continue treatment and it's cruel to do so. In those circumstances, you should not be continuing treatment, and in those circumstances, you should not be resuscitating. However, where you're obliged to continue treatment because you're trying to save the person's life, if they collapse, then you should be resuscitating. So the two go very closely hand in hand. Do you know what? Can everybody move their chair 1 step forward so those people can fit in at the back? Just move your chair 1 meter. Okay, what I'm going to do is try to give an overview of the principles governing end-of-life care, continued treatment, withdrawal of treatment, and that'll be very clearly related to the resuscitation question. There are many subcomponents here, the brain death debate, and many other sub-issues. We won't have time to deal with everything in detail, but I'll try to paint you a broad picture, and then I'll take questions, things that I've forgotten or not clear. You're very welcome to ask. Let me just start with a reference. I wrote a textbook about this some time ago that's called Dangerous Disease and Dangerous Therapy. That has a lot of details with all the references and the background and the derivation for many of the things that we'll talk about tonight. If you can't get a copy, you can email me. I'm very happy to download you the relevant portions, the parts of the book, with very great pleasure. You can always call or email me. I'm not the last word on this, but I do spend a lot of time working in this area. Very happy to help when you want to talk through various problems. There are people in the room here that we do this repeatedly. Dr. Castle could probably tell you this lecture in his sleep. But you're very welcome to do that. It often helps just talking it through with somebody else who's not in the situation. You're very welcome to do that. Let me give you an approach to end-of-life issues, and I think that will give you a framework on which to hang all of these questions. The logical way to do this is to deal with the exceptions. In other words, the basic Jewish approach is we try to save life, right? Under virtually all circumstances. That's the default position. That's how we begin. For example, we break Shabbos to save a life even for 1 second, even a life of no quality. Person who's unconscious, they'll live for 1 extra second. You work all Shabbos, breaking Shabbos, for the off chance of being able to save a person for 1 extra second. We belong to that old-fashioned attitude medically. We're trying to save life. We don't stack up quality of life in the default position against saving life. We'll do almost anything and spend almost anything to save life. Again, there are plenty of exceptions, but that's our default position. So the easy way to handle the situation is, what are the exceptions where you do not have to do everything to save a life? But I make that point clearly because going into the question of when you can stop makes it sound like we are into stopping. That's not our basic position. We continue, resuscitate thoroughly, and as long as it takes till there's a vanishingly small chance that the person will recover, we try our best to save life. What are the exceptions? So in order not to treat or to withdraw or withhold therapy in an end-of-life situation, you need a range of criteria. 3 basic criteria. I'll say them briefly and then try to go over them in detail. The 3 things you need when you will decide not to treat someone, that is to withhold treatment, and in some specific cases to withdraw treatment, you need the following 3 things. You need somebody who's terminally ill, who's suffering uncontrollably, who does not want to continue. You need all of those, not just one of them. Somebody's terminally ill, we'll define all this carefully. Somebody terminally ill, suffering uncontrollably, or alternatively unconscious with no hope of ever regaining consciousness, that counts as well. Thirdly, who does not want to continue. If you have a full house of all of those 3 things, you should not be continuing. You're just cruelly prolonging the suffering of somebody who's suffering uncontrollably, dying anyway, and doesn't want to continue. All the poskim, the halachic authorities that talk about this, like Rav Feinstein, make it clear that it's not just not an obligation to continue, you should be stopping. Because you are just causing prolonged suffering, that's where you stop treatment. Let's go through the criteria in more detail. You need somebody who's terminally ill. This is halachically called somebody who's chayei sha'ah. Chayei sha'ah means temporary life, or what we call in English terminal life. I'm not talking about extreme end-stage agonal stage. That is a separate halachic category called goises. Goises means somebody who's gasping, gurgling, they can't clear their secretions, they're dying now. The Talmud says people like that don't survive for 72 hours. That's got a whole different set of laws. If there's time, we try to deal with it. But I'm talking about somebody... Dr. Lieber, you have a seat? There's one right here. Dr. Lieber saved my eye last night in an incredibly creative fashion, so I thank you publicly. That's got a separate whole body of law dealing with the person who's actually dying in extremis. We'll deal with that if there's time. So you need somebody who's terminally ill. Halachically, there's quite a broad definition. That means somebody who will die within a year. Again, without going into the background of derivation, that's a pretty broad definition of terminal illness. Somebody that a consensus of expert opinion is that this person with this stage of their disease, with their age, etc., would not survive for a year. Very interesting to know, during this talk I'll try to show you a number of issues that are governed by Israeli law. Some of you might well end up practicing in Israel, you might end up living there, you might have some decisions to make. Israel has a range of laws which are absolutely unique. Being a secular country, there's no democratic motivation in Israel to do things according to halachic standards, and yet there are a number of laws in medical ethical arena in Israel that accord unusually well with halachic principles, and one of them is this law that's known as the law of the dying patient. The formal name of the law in Israel is passed, I think, in 2008. It's called Chok HaCholeh Anotel Amut. That means the law governing the dying patient. As a very interesting law, it first of all defines end of life. It mandates palliative care. It exempts the doctor from legal consequences if the patient dies when he's trying to administer, let's say, pain relief. And I'm not talking about negligence, I'm talking about well-motivated. It also permits withdrawal of treatment. So it's a very significant life and death law. And the law defines terminal illness as 6 months and not a year. Very interesting. The Knesset took the view that they ought to be more conservative than the right-wing religious authorities. That's very unusual in Israel. Okay? In fact, this law was passed by the Israeli parliament on the basis of a committee of 47 expert Israelis, members of parliament, 1 or 2 Arabs, a few professors of medicine, some right-wing Orthodox rabbinic advisors. Can you imagine 47 Israelis on a committee? You know, I mean, 3 Israelis discuss the weather, it gets dangerous. You know, you're talking about 47. Amazingly, there was almost unanimous agreement on most of the points of the law, and the Knesset decided against rabbinic advice to tighten the definition of terminal illness to 6 months from a year. The rabbi suggested that they use the halachic criterion, which is a year. The Knesset decided that it's more difficult to prognosticate that a person will die within a year than within 6 months. And therefore, since this law mandates withdrawal of treatment and dangerous interventions to relieve pain, etc., they wanted to be more cautious and more sure that the patient's terminally ill. So although the rabbis were happy with a 1-year definition, they decided to be more conservative, and the present Israeli law defines terminal illness as 6 months. Right? Very, very amazing. And that's the law in Israel today. That law has many other interesting features. If we'll have time, we'll talk about that. So that's the first criteria. A person's going to die within a year. That is the definition of terminal illness. Secondly, the person's got to be suffering uncontrollably. This should never happen in modern medicine. It really should never happen. I'm talking about 2 categories of suffering. One is physical pain, and the other, which is much more difficult, is psychosocial issues that are family-related, depression, all kind of. Those are much more intractable often than the physical pain. Nobody should be dying in uncontrolled physical pain today. We have enough tricks and tools in our basic armamentarium. Especially today, pain relief is a field of expertise. You can actually specialize in it. Today, nobody should be dying in extreme pain. We've got very clever nerve blocks and drugs we can use, and therefore, nobody should be dying in pain. It is true that sometimes to relieve pain adequately, you've got to do things that are dangerous. That's true. Halachically, that's not only is it no problem halachically, you're obliged to do that. Let me make this clear. Somebody is terminally ill. They're very frail and they're fragile. They're in extreme pain. You know that to relieve the pain, there will be a compromise of safety. You're going to give them morphine, and to give enough morphine to relieve the pain, you may compromise their breathing, let's say. Usually the problem is, what gives you the right to do that? The upside is you relieve pain. The downside is you might kill them. That doesn't make sense. Again, in Jewish law, there's no question you can do something dangerous when the upside is you'll save a life. The downside is it's dangerous, you might kill them. The upside is you might save a life. There's room to do that, and we'll talk about the criteria. But here, the upside is not saving life, it's just relieving pain. The downside is you might kill them. In fact, the old medical approach, and my father was a young doctor, the approach was let the patient suffer. Don't take a chance of killing them, right, to relieve pain. That was the basic approach. Judaism says absolutely not. Even though the upside here is not life-saving, it's only pain relief, you're allowed to countenance and accept a dangerous intervention, even though the benefit is only going to be to relieve pain. What's the rationale? There are a number of features here, but I'll just tell you one classic one, again from the writings of Moshe Feinstein, but others say the same thing. He writes very beautifully, the reason you're allowed to do something dangerous to relieve pain is because any experienced doctor knows that the patient's pain is relevant to their survival. A patient is desperately ill, anguish, hopelessness, abandonment, severe pain. These things are tangible, additive, lethal factors. And therefore, to relieve the pain is not only humane, it's actually also life-saving. Right? That's a logic worthy of any experienced doctor. And what the rabbi said. And therefore, if you need a rationale, if you need to give pain relief, and the benefit is going to be relieving the pain, the downside is the treatment might be dangerous, Judaism mandates doing that. So there's no excuse to let anybody suffer. You tell me it's going to be dangerous to give the drug, whatever it is, that's your problem, you need to do it. There are... What?
What was the rationale of your father?
In my father's day, the teaching was you've no right to do something dangerous that might compromise the patient's life in trying to save pain. It's not going to save them. Rather let them suffer a bit more and stay breathing. Right? But there was... Okay. That's not the way we do it. However, there are a number of important conditions. So let's say you're going to give a drug to relieve pain. Here are the conditions. Listen carefully. Number 1. Of course, the medicine must be given to relieve the pain, not to kill the patient. Across the world today, this is commonly not observed. You often walk into a situation like that, you'll find an unconscious patient, there's morphine running. Why is the patient getting the morphine? Suffering. The patient's not suffering, they're unconscious. If you scratch beneath the surface, you'll find it's actually the family that's suffering. So there's been orders to run in morphine. I mean, this is very problematic. This takes us into the whole discussion of hospice. If there's time, we'll talk about that as well. So it's got to be obviously titrated carefully against the pain, so there's no intention to kill the patient. Secondly, only the most qualified doctor is allowed to give the medication. And the reason is the Code of Jewish Law writes black on white that no doctor is allowed to touch a patient if there's a more qualified doctor around to do so. And let me repeat that. In our modern medical environment, junior doctors do things because they need to learn. The Jewish attitude is they're learning wrong because they're learning that the patient doesn't get the best. And therefore, the professor's got to come down and do this dangerous procedure because the patient has to get the best quality of treatment, and no junior is allowed to do it. The junior has to learn. That's a separate problem. We'll have to figure out a way to handle that problem, but the patient needs to get the best. There are exceptions to this rule. The most qualified doctor does not need to be the one to do it when either the most qualified is fully engaged, so now we need to call the second most qualified into action, or the procedure is well within the capacity of a junior, then you don't need to fuss to get somebody more qualified. Or thirdly, the procedure's been done under the direct guidance and responsibility of a senior. That's also acceptable. But the basic principle is the patient has to get the best, and therefore there's no question of getting somebody unqualified when somebody better could have done it. Provided all that's being done, then this dangerous modality is being used in order to relieve the pain. That is now, psychosocial suffering, that is a much more difficult issue. Here you need real expert assessment. Is the patient saying they don't want to continue because they really don't want to continue, or is it because they feel they're a burden to their family, they're unduly depressed? This is a whole tiger country, and it's often very hard to assess. But the basic principle is that the person needs to be terminally ill, suffering uncontrollably, genuinely. That means uncontrollable suffering, not because the family's burdening them or because you didn't treat the pain adequately. But if they're still suffering uncontrollably or unconscious, with no hope of ever regaining consciousness, and under those conditions do not want to continue. Now, how do you know the patient doesn't want to continue? Let's talk about that. Here's the order of business. Best option of all, you ask the patient, what do you want? This is problematic for many reasons. First of all, obviously, sometimes the patient can't tell you. They may be demented, they may be a baby, they may be unconscious. There are a lot of situations in which you don't know what the patient wants. But there are other reasons as well. Sometimes you don't know what they want because you shouldn't be telling them that they're terminally ill in the first place. The Code of Jewish Law, again, is clear. You cannot do anything that will prejudice the patient's survival. If you're going to give them desperately bad news and the shock is going to beat them down, you're not allowed to do that, right? The standard in American medicine today is complete disclosure, right? Even with children, to a bizarre degree. Some of them call it truth dumping. Truth dumping, right? You walk in and tell the patient like everything, vastly more than they can possibly absorb or understand technically. You've got to tell the truth, otherwise you're legally in trouble. Jewishly, you're not allowed to divulge information that is going to harm the patient's health. Obviously, sometimes you need to tell them they're desperately ill because they have to give consent for something. Obviously, you can't ask them if they consent to chemotherapy if you just told them they got flu. So obviously, there's times when you have to discuss it. But it has to be very carefully done. First of all, the Shulchan Aruch Code of Jewish Law says you're not allowed to tell somebody who's desperately ill that a family member's died. Even if they have halachic obligations of mourning, you have no right to prejudice their delicate situation by giving them bad news. Secondly, you're not allowed to cry in the room. Somebody desperately ill, the family suddenly gathers. Children from Canada, grandchildren from Australia, they gather around them and start crying. That's not good, when you're lying there hoping to recover. Right? So you have to be very careful about this. And so telling a person they got a desperate prognosis unnecessarily, that is not allowed to be done. The Talmud says if there's a sword on your neck on its way down, you're still not allowed to give up hope. When bad news has to be given, it has to be done very carefully. For example, number one, you have to start with a message of hope. You don't give the bad news first. You start like I'll just give you an example. The Jewish confession that's done before death, you can look it up in the Siddur. You'll see very beautiful short phrasing. It begins like this. This is the confession that you say before you die. It says, Hashem, God, my healing is in your hands. May it be your will that I recover from this illness. You start positively. And then you say, but if I don't, may my death be an atonement. And then you say your confession. So it starts positively. The Code of Jewish Law and all our codes say that when the doctor gives bad news to the patient, you have to walk in and start like this. You say, your medical situation, many have been in and recovered. Okay, that's the good news. Now, it's a difficult and dangerous situation. Many have recovered, but we need to do X, Y, Z. You start with a positive message, no matter how unrealistic. One of the problems with hospice, certain types of hospice, there are two types of hospice. One, you can go for treatment. Other types, you only go for terminal care. That's unacceptable Jewishly. Because people know you go into that sort of a hospice, you don't get treated, no one gets out of there, you're going to die. The good news about places like that is you die very well. Very well. Comfortable, excellent pain relief, dignity, very, very well done, lovingly done. However, you know you're not going to get out of there. And they might as well write over the door, abandon hope, all ye who enter here. That's unacceptable, Jerusalem. Right? Even if it's true, you're not allowed to tell a patient, you cannot deprive a person of all hope. And therefore, it has to be very careful what you are telling the patient. But if the patient does know, then you have to ask them what they want. There are two circumstances where their opinion is all important. One, continuing life-saving treatment when they're desperately and terminally ill. Two, to undertake something risky that might save them but might kill them. You have no right to make that decision. The patient has to make that decision. That happens to accord very well with the secular ethic of autonomy, that we ask the patient what they want, albeit for different reasons. So let's go through it again. This person is desperately ill. You need to ask them, do they want to continue? If they're of good, sound mind, and you can ask them, then that is what you do. If you cannot ask them, the order of business thereafter is this. Did they ever express what they wanted in these circumstances? If that's clear, then you do what it is that they said that they wanted. Who do you ask this? By the way, Israel again has a very interesting law. You know, many countries throughout the world are encouraging advance directives. They want people to stipulate beforehand so that you don't have to go through this messy business when you cannot ask the patient anymore. Obviously, that's a good idea when it's correctly done, but at the point of care in emergencies, it's often quite hard to get the information to hand in a reliable fashion. Israel has a remarkable system here as well. The Israelis have come up with an online advance directive. You go online, you fill in your name and Israeli ID number, you fill in a very detailed questionnaire about what you want done to yourself under situations of extreme, emergency. You want to be ventilated, etc., etc. And it's accessible 24/7 at any point of care in Israel. So you take an ambulance is wheeling you into the emergency room, whatever it is. They go online before they start treating you, and they can see immediately what your personal advance directive is. It's only valid, by the way, if it's updated every 5 years. Because a lot of research has shown that what people say they want done when they're older while they're young doesn't turn out to be what they want when they're older. And it has to be updated if you're given a serious diagnosis. Because a lot of research has shown that what people say they want done to them when they're sick, when they're not sick, does not turn out to be what they want when they are sick. Right? A couple of years ago in London, a lady came to see me. She told me, she sat down at my desk and she said, I've just come to say goodbye, I'm about to commit suicide. Right? She had terrible, real suffering. She had a lot of problems, and she said, I've tried really hard. I cannot take it anymore. I want to thank you for helping me in the past. I'm about to commit suicide. I sat there sweating and shaking for half an hour, trying to show her that life is worth living. Okay, she's agreed to live for another week. Next week she comes in, thank you, I've tried. This is it, goodbye, killing myself. Same thing. For 18 months, I had sleepless nights. Every week I would talk to this lady. 18 months later, I get a call from her. You have to see me, it's an emergency. She comes in, what's the problem? I've just been diagnosed with breast cancer. Save me! I said, one moment, this is okay, isn't it? No, save me! She went through very aggressive treatment, and now she's thrilled to be alive. Go figure, right? Okay. So, what it takes. The point is, she's one of the happiest people I know now, right? Amazing. So, the point is that if there was an expressed wish beforehand, then that is what you need to do, provided there's no evidence that that was done under duress or some improper motivation. If there's nothing like that documented, the next port of call is you ask family members. Which family members? The one or ones that the person would have trusted. Moshe Feinstein writes that you ask children for parents and parents for children, because the halacha assumes that the default that parents normally trust their children to make the best decisions for them, and children trust parents to make the best decisions for them. It might be a spouse, it might be a parent, it might be a child. The person that the person would have trusted is the person you ask, because there's a default assumption that they would have asked that person. First you ask the person what the person who's dying wanted or would have wanted, and if they don't know, you ask them what you think is best for them, because they would have trusted your decision, right? And that is how you handle the situation. You ask a family member. This is often very problematic. Sometimes it works extremely well, and sometimes it's very problematic. Classic areas where it's problematic is where there's conflict in families. First, we're talking about asking a person that clearly was trusted by the person, right? Not the family waiting for the inheritance, and problematic motivations. We're talking about where there's no reason to suspect any problematic motivation. We see conflicts in families all the time. There are many situations, but one classic one is where children some are more religious and some are less, and there's a very harsh split of opinion about what should be done for the mother, grandmother, etc. Right? We see that, I think, probably every week. I'm involved in some situation like that where there's conflict in families. Sometimes a classic form of conflict is everyone agrees that the parent probably would not have wanted to continue, but the kids are so-called balei tshuva, they're more religious, and they're very keen that the parent should continue, even though they're ready to admit that the parent probably wouldn't have wanted to. But they're very motivated to keep going, right? It can get extremely messy, and conflicts badly handled at that time can rift families for a long, long time afterwards, and it's your skill working with families that can provide tremendous healing. Very often families who've been conflicted for a long time, you can bring them together at a time like that, if you handle it well. And experience shows that there are some techniques and approaches you can use that make it easier, but often it is very difficult. Let's give you an example. I mean, there's so many examples. I'll give you one. Some time ago, I got a call from a big hospital in London. It's a lady consultant on the phone. She tells me, I'm the palliative care consultant in this situation. The problem is we've got a 72-year-old Jewish lady who collapsed 2 days ago, healthy until then. Turns out a widespread ovarian carcinoma. She's in intensive care. She's on all kind of tubes and machines. And she's a secular, traditional Jewish lady. And she's got 2 newly religious children, right, who are very, very keen about doing things halachically correctly. And the problem is that I would like to withdraw treatment. This lady's hopeless. She's got widespread cancer. She's suffering. I want to withdraw treatment. So, and she's calling me because I suppose the children have told her that she speak to somebody Jewishly who knows about these things. So she tells me, this doctor, that she's convinced that the patient does not want to continue. Why? Because in Britain you need consent. So she wanted to get the patient's consent. How did she get the patient's consent? She said, well, I and another consultant, we walked over to the patient and we said to her, now listen, this is Britain, you can understand the way they do things there. We leaned over and we said to her, dearie, if you become poorly, right? This is British euphemistic, right? If you become poorly, would you like us to continue? And she shook her head. Now, in my book, that's not consent. Here's a half-conscious lady, traumatized, okay, but the interesting point, though, is that the children were ready to admit that the mother probably would not have wanted to continue. They knew their mother very well. And they admitted that to continue in pain, an undignified end like that, she probably would not have wanted. But the 2 children, son and daughter, were very, very keen that the mother gets all unlimited treatment under all circumstances. So the doctor says to me, well, look, my duty as a British doctor is to follow the patient's wishes. Not only do I consider this futile treatment, but it's clear to me that the patient would not want to continue. I want to stop all treatment. The children are having an extreme reaction to that. So she asked me my opinion. I said to her, in our religion, it's really not what the children think, it's really what God thinks. Long pause on the phone. Long pause. This is a British, crusty type, Well, she said, that's fine, but that's not British law, He doesn't come into our law. And therefore, I want to stop treatment. What happened, in fact, was the kids threatened to sue the hospital. They called the General Medical Council. They made a big fuss. So they continued treating her. She died 4 days later. But you can get all sorts of conflicts within families against the system. Conflicts with the system is another whole problem. But that is a very common situation. Israel, again, here has an amazing resolution of this. In Israel, the Knesset took the view a few years ago that these are not legal issues. In other countries, when there's enough conflict, it ends up in court. In a classical American situation, somebody gets to the Supreme Court, famous cases, Cruiser and Karen and Quinlan, this famous case in America that set precedent. The Israelis took the view that these are not legal matters. And when there's a conflict in a family, or conflict with a hospital, the doctors feel it's futile, the patients want to continue, you cannot take this to an Israeli court. What they've done is they've set up regional ethics committees around the country. The ethics committees consist of local medical experts. Any expert you would like to co-opt onto the committee, you can have a family member speak at the committee as well. You have a say in constituting the ethics committee. If you disagree with the outcome, you can appeal it to a national ethics committee in Jerusalem. I know one or two people sit on that committee. And if you disagree with the outcome there, you have no further recourse. You cannot take it to court. The parliament took the view, these are cultural, religious, personal, family matters. They're not legal matters. And therefore, court is not the place to settle these issues. If you claim there was some legal impropriety in the process, you can challenge it in court. But provided you can't say anything was done improperly during the process, that is the way the issues are resolved, and it's probably a good system. So that is the way it's handled there. Finally, what happens if there's no family member you can ask? then our halachic authorities are clear. You default to what the average citizen would have wanted. Again, this is a fully orthodox approach. Again, you'll find it in the writings of Moshe Feinstein. What would the average person in the street, in Britain, it's called the man on the Clapham omnibus. Right? That's what it's called. Believe me, the man on the Clapham omnibus is probably a heavily pierced, tattooed individual. I don't know what his attitudes are to life and death, but that's the man you ask. In Judaism, you ask what would be the opinion, not necessarily of Jewish society, of broader society in general. And sometimes it's very clear. You've got a newborn child who's got multiple surgical abnormalities. He's not going to live for 6 months. With a lot of painful surgery, he might live for 8 months. Most people would probably agree that's just not appropriate. And since there's a general agreement that most people would agree with, then we can assume that this person, child or whoever it is, would go along with that opinion, and that would be your last protocol. By the way, for children, you ask parents, not the biological parents, if they've abandoned the child. So if parents abandon the child's taken care of by a hospital team or an adoptive set of parents, they're the ones who make the decision for the baby, not the biological parents. They've given up their right to make life and death decisions for a child they've abandoned. So let's go over it again. You've got a terminally ill person. You've got a person who's suffering uncontrollably. Under those circumstances, they do not want to continue, either because they've told you or we've established it by the various methods that we have talked about. In those circumstances, says Rabbi Moshe Feinstein, and there's no disagreement about this halachically, you're obliged to stop treatment. Not you may stop treatment, you're obliged to stop treatment at that point. However, there are a number of conditions that govern that withholding of treatment. Let me express a few of them. One, this only refers to treatment. It does not refer to basic and staple needs. So this patient's not going to get chemotherapy, they're not going to get surgery, they're not going to get treated. But you may never withdraw a basic staple that the person ordinarily would have needed. So nutrition, fluid and electrolyte balance. If they're diabetic, they continue getting the diabetic medicines or their thyroid, whatever basic stuff they were getting that kept them going at baseline. You can't kill them by withdrawing something that they ordinarily would have needed. That's completely unacceptable. Nobody is allowed to be starved to death in Jewish law, and no one's allowed to dehydrate to death. That's completely unacceptable. You can't do that. This is commonly done, I have to tell you, again, in hospice situation. I've seen hospice patients not allowed to drink a cup of tea because the doctor's written up nil by mouth. They've told the family that food is only risky, it's going to harm the patient. Old people begging for a cup of tea, they let them suck a piece of ice, okay, because they're not per mouth. It's completely unacceptable Jewishly. No one is allowed to starve to death. Now, let's go into a bit more detail. If the person is dying within a few days, you don't have to feed them. You probably will do more harm than good. People who are very wasted and not absorbing their nutrition, you're probably only going to cause more danger by feeding them. There's no obligation to feed somebody like that. But if they're dying in 6 months and you don't feed them, you will starve them to death. That's not acceptable Jewishly. If they're dying today, they don't have to get liquids. It's not going to make any difference. You're probably going to harm them with the liquid. Some are going to run it in too fast. They're going to get overloaded. You don't have to do that. But if they're going to die in 2 weeks' time and you don't give them liquid, they will dehydrate to death. That's not acceptable Jewishly. Can you hold the questions? Please, I will take questions. But just note it down, don't forget. They have all sorts of illegitimate tricks. In England, in some places, they put a needle under the skin and they tell the patient, well, we're hydrating them, they're going to absorb it from the subcutaneous tissues, right? That's not acceptable. It is true that hydrating and nourishing very sick people is a serious medical technical problem. It is true. Sometimes, especially in a non-intensive care situation, like a side ward or a hospital situation, they're going to get fluid overloaded. That is true. It can be dangerous. But you have to have some tricks up your sleeve. I personally, when a patient's in a situation like that, I use a pediatric giving set because nobody can overload them accidentally. So it'll take 24 hours to get the fluid. You'll have to do it over a longer period of time, but no one can inadvertently open it and put them into pulmonary edema. You have to know a few clever tricks that you can use that are going to protect the patient against some accident that will still give them what they need. So that is with regard to liquids. Food can be extremely challenging. Nourishing people who are very sick is a real technical problem. Very often the doctor will say, look, you're the rabbi, here's my problem. If we don't feed this patient, they're going to starve to death. On the other hand, we can't feed them, they're not absorbing their food, they're swallowing badly, they're getting pneumonia, so what are we going to do? I say to them, doctor, that's your problem. That's a medical problem. You solve the problem technically, I'll help you, but halakhically, you cannot starve this patient to death. What are the solutions? Okay, again, we're talking about somebody who's expected to live long enough that the food's going to make a difference. Under those circumstances, you have a number of options. Obviously, if you can get away with tube feeding, then that's an option to do. One of the vexed issues is, do you do some sort of enterostomy, gastrostomy, jejunostomy? What do you do there? Classic problem is if you leave it too late, the surgeons won't do it for you. They tell you the patient's too frail, we can't do it, and your options are closed. If you ask for it too soon, they say the patient's not sick enough. They're still eating, right? So now that needs a careful community-wide policy. In England, there's a very well-known policy. There's some wonderful geriatricians and people who work in this field, and the new General Medical Council guidelines in England make it clear that the treating doctor needs to take the patient's cultural and religious values into account. 2 years ago, there was a different set of guidelines. It was extremely contentious. The new ones are very friendly to Jewish criteria. Once you have that and the doctor's calling in the rabbi, right, or some consultant from the patient's, and this applies not just to Jews, by the way, it applies to Muslims and others as well, it's a lot easier to work. There's a community-wide awareness now that we ought to get these things done rather sooner than later. Because if the patient gets too malnourished and too frail, they're not going to do this for you. And then they know that very often, although it's a procedure that looks like a little bit early, at least you can have a route of feeding the patient. It is true that's a very challenging issue, but despite that, somebody's not allowed to be starved to death. If the patient refuses to eat and it becomes a wild battle and they're going to suffer while you try and force them, you don't have to force them. In that circumstance, you don't have to. But ordinarily, you're obliged to provide adequate liquid, oxygenation, nutrition. Not every dying patient in Judaism needs to be ventilated. Not every dying patient needs to be dialyzed. Absolutely not. Unless there's a specific reason. They can't breathe and they're suffering air hunger and they're feeling like they're asphyxiating. You have to ventilate them. That's very cruel to leave them at that source. But they're generally winding down and all their systems are basically shutting down. It's not a specific failure of one issue. You don't have to dialyze and ventilate everybody who's in that situation. Absolutely not. So that's with regard to basic and staple needs that you're not allowed to withdraw. And finally, you are never allowed to withdraw something that's actively keeping the person alive. In other words, to do something that actively shortens a life in Judaism is considered killing the person. You can't do that. So if they're getting an IV that is keeping the heart beating, and you switch it off, that you cannot do. They're on a machine that's ventilating them actively. You can't switch off the machine. You shouldn't have put them on in the first place, maybe. Okay, we'll talk about those circumstances. But if they're on a machine that's keeping them going, or any continuous modality that is keeping life going, you can't switch that off. That's killing the patient. We don't have this distinction. That's omission and not commission. We don't have that distinction. Doing something that is killing the patient, that you're not allowed to do. So that is actively killing or shortening life. However, if the mode that you're using is not continuous, it is intermittent, you can withhold the next administration. So let me give you a few examples. The person's not getting a continuous infusion, but every 6 hours they're getting some drug that is keeping them going. Don't give the next bolus. Don't give the next drug. That's fine. You didn't stop it. You just, is this clear? You withheld it. They're being dialyzed 3 times a week. And we get to a position where they're terminally ill, suffering terribly, don't want to continue. Don't do the next dialysis. That's clear. That's okay. But you can't stop. Is this clear? You can't. Don't put them on the ventilator in the first place. But once they're on it, you're not allowed to switch it off. So you can't do something that will actually, call it euthanasia, whatever it is, not allowed to do something that foreshortens or ends a person's life, but you can withhold something that you didn't start or that you're intermittently using. That is what you're allowed to do. Let me make one final comment here, and I'll stop for questions. There are a lot of other issues if there's time. We can also talk about the question of doing something that's very risky, that might save life. But let me just add one final word here. There is, in the near future, almost certainly going to be a whole new option here, which is ventilators with timers. Ventilators. Let me explain this to you and make it clear, because in my opinion, coming to a hospital near you soon is going to be a ventilator system that has timers. In Mount Sinai Hospital in New York, they told me they're now considering using these timers for their ICU ventilators. And I'll explain to you what it's all about. Shaarei Tzedek Hospital, together with Hadassah, has actually built machines like this. They've used them on non-human models. This is a ventilator that is timed for a specific amount of time and then switches off. Okay, so this will run for 3 days or 5 days or 8 hours, whatever it is, and then the machine will switch off and the patient will die. Preset, and the patient will die at a certain point in time. This has, believe it or not, extreme right-wing halachic acceptance. Rav Zilberstein proposed this 25 years ago. Rabbi Yashiv was in agreement. I don't know anyone who disagrees. I'm sure there'll be very active debate about it. No one's yet talked about the exact protocols and the timings, but it's about to happen. They perfected the machine. It took about 2 years to build electronic circuitry that switches off a ventilator at a predetermined interval. You might find that surprising, but the doctors then will tell you why that is, right? You can't simply get one of these Shabbat timers and put your ventilator into it. The reason is because if you cut the power to an intensive care machine, the machine doesn't agree to switch off. It's built not to switch off. It's got its own backup systems that start squeaking and squawking and bleeping at you. You can't switch them off. So the Israelis had to come up with a system that will switch off the machine when you want it to, but not override the fail-safes and let it switch off inadvertently. That's life and death in a little electronic circuit. They've now got it working well enough, they feel it's reliable enough. They're now putting together a human trial. It hasn't happened yet, but they've selected about 20 people. They're about to run a human trial. People that are going to put on these machines told that in 5 days the machine will switch off and we will not switch it on again. Let me try to explain this. It's very important to understand how this works. The wrong idea is that this is a cowardly way of putting people in situations so that they can die because we don't want to switch off machines. That's completely wrong. And in fact, if you did use a machine like that and it switched on and it switched off and you were standing there, you'd have to switch it on again. There's a prohibition in the Torah of standing idly by while somebody dies. So all else being equal, in fact, you couldn't do this. Yes, it's less serious than killing them directly because it's said at a distance. Halachically, you probably couldn't be tried for murder, but one is not allowed to do that. However, there are plenty of valid scenarios where it might well be used. Let me give you a couple, and I think you'll see the logic here. Again, this is not designed to be a killing at a distance. That is not the idea at all. That would not have halachic sanction. But I'll tell you scenarios where it could very well be a halachic solution. Here's one. Patient comes into your hospital. They're 75 years old. They've been smoking for, 60 years. They've got terrible lungs, and you need to put them on a ventilator. The trouble is, you may get them on a machine and you may never get them off. And they don't want that, and you don't want that. And not only that, the 3 months they'll spend on your machine, other people will die because you don't have enough machines, right? And even South African doctors can't always tell exactly who's going to live and who's not going to make it. You don't know who's going to respond to the antibiotics and recover, and who's not. What's the solution? The classic solution, and some of you in this room have been in that odious position, you try to select those who look like they're going to recover, and others just get sent home to die. And we don't always make that call correctly, and no doubt people have been allowed to die because we didn't give them the option because we thought we'd never get them off. New solution. Don't make that odious choice. As soon as the person comes in, put them on the machine, but say to them, my dear sir, this machine works for 5 days only. If during the 5 days you respond to antibiotics and you look like you're getting better, we'll keep you going. If it's apparent that this is the end and we cannot help you and you're not responding, in 5 days' time, when the machine switches off, we will just allow you to die. Or more accurately, we'll put it on someone else. You could never accuse the medical team of using the machine to kill the person. You gave him 5 extra days. You gave him a trial of therapy that he wouldn't have had otherwise. His option was to be sent home with no treatment. Is this clear? You didn't use this as a way of killing somebody. You gave somebody an option that's only going to tie up a machine for a few days. That had he recovered, he would have continued. Is this clear? So that is a very wise, I would say, use. Again, I don't want to take sides here. This hasn't been finally worked out. It hasn't been asked in practice yet, but this is inevitably what. I'll give you another scenario, and you can think of many others. Here's one that may or may not accord with Jewish law, but the non-religious team that is building the machines has promoted this as another scenario. And again, as I say, there are many. 3 o'clock in the morning, you get a very old person, you come into your hospital, desperately ill, unconscious, they need to be ventilated. You don't know what their wishes are. You can't find documentation. It's 3 in the morning, no one's available. You put them on a machine. 8 o'clock in the morning, a son or grandson walks in and says, what have you done? My grandfather was very clear. Here are the documents. He definitely stated that he didn't want to be ventilated. Now you're in trouble. This person's on a machine. You can't switch it off. New solution. No problem. This machine only runs for 8 hours. That's all. And if it becomes apparent that this is a person who didn't want to be saved, that's cool. 8 hours time, we just don't switch it on again. Right? Whereas previously you would be stuck in a situation where you didn't have that option. That is a very interesting solution. I have very little doubt this is going to be rolled out. I think it'll be rolled out throughout the world. This will solve many triage problems where we can't afford to put people on machines because we don't have enough of them. In many communities in America, there's been debates about widespread viral, flu-type epidemics. We'll have to make selections. In Detroit, I was in Detroit recently. They co-opted the young Orthodox rabbi there into the ethics committee of the hospital. What happens if we have a swine flu epidemic? Who are we going to save? The committee decided that we'll ventilate all children and send all adults home to die. Because we can't save everybody. We'll choose children. We won't choose adults. You have to make these decisions. Now we may be able to obviate that by using the machines for whatever periods of time we'll decide, and that is going to be a very interesting solution. And again, I'm sure it'll be a vexed issue, and I'm sure there'll be active debate about it, but I've very little doubt it's actually going to happen. I'm going to stop at this point because there may be questions. If there's time, I'll try to address as well the very interesting question of when can you do something to save a life that may be so risky that it might kill instead. But first, are there questions on anything that are... Yeah, sorry, there was a lady who had a question.
Sorry, I'm just trying to correlate. On the one hand, we say that if there's a sword on the person, you just save them. On the other hand,
you don't give up hope.
Right, you don't. Right, you
Yeah.
don't give up hope. On the other hand, we say if a person's got an hour to live or 2 days, who are we to kind of make that decision? Even
if that's how you feel, then your decision is to keep treating me. That's fine. But if the person's suffering so badly they can't continue, then you have no right to force them to continue. Hashem's in the picture too, right? He's put this person in a situation. He's telling the person, you're definitely dying. I can't control your pain. You're suffering. You have the option. If the person says, I don't want to continue, of good, sound, solid mind, then you stop. And you leave it up to him. By the way, if they say, doctor, get me to that bar mitzvah of a grandchild in 9 months' time, keep going. If they want to suffer and continue, get them there, by all means. This is the person who does not want to continue. Who are you to put them through uncontrollable suffering?
Yeah, but now since they're unconscious,
Yes.
then who's looking around?
Only them. Only them.
So you can't-
Only the patient. So how do we do
What
it?
about the general population, the common...
That's only because we assume it's a proxy for their decision. Let me be clear about this. This person is unconscious or demented. We cannot ask their opinion. We get as close as we can to what their opinion would have been. That's the halachic concept. So, did they ever express an opinion? That's their opinion. Do the children tell you what they wanted? Do the children tell you, knowing that patient well enough, what they would have wanted? That's good enough. Failing all of that, what would they probably have wanted? What does the average person want in us? We can't do better than that. It's very rough, but it's as close as we can get to assessing what they probably would have wanted. And if most people in society would have probably wanted to continue, we'll continue. By the way, when in doubt, keep going. If you're in doubt, obviously we are on the side of saving life. Is that clear? Yes.
Rabbi, I just wanted to ask you a question with regard to a scenario, for instance, in states, in an ICU setting, where the Jewish doctor may not be the most senior doctor treating the patient,
Yeah.
and a decision is made to withdraw care.
Yeah.
And even if we may be involved in the case, what happens numerous times is that they will not switch off a ventilator, but they will stop inotropes. And you're saying that if there is continuous therapy,
Yeah.
you can't use the continuous therapy as the decision to withdraw care. So in that situation, what is the Jewish doctor's responsibility?
Yeah.
Do we need to advocate
Okay.
on the patient's behalf?
Yeah. Can I generalize your question?
Please, yeah.
What happens when there's a conflict between you and the ethic of the society or the law of the land? There's a whole talk in its own right. There's good news and bad news. The bad news is we often find ourselves in situations where we conflict with the ethic and the law of the land, okay? Very often. Because the pendulum has swung largely in the last few years towards not saving people, letting them die with dignity, not imposing endless life-saving, etc., etc., whereas moved beyond the Jewish position clearly. So we often find ourselves in that sort of a conflict. That's the bad news. I've been in that situation in conflict with the law of the land like in 4 countries in medical practice. That happens like all the time. Even in Israel, unfortunately, which is not run on religious lines. The good news is that they're almost always ready to accommodate your religion. Catholic doctors will not do abortions. Catholic nurses will not give abortifacient medications. Pharmacists will not, and they're respected. In a democratic Western society, you have a right to your religious views, and they'll respect that. They may say, stand back, we'll get someone else. Okay. You don't have to lie down on the floor kicking and screaming until the police drag you away. Okay, you don't have to do that. So yes, you should advocate. They will respect you. If you're a knowledgeable Jewish doctor, nurse, whatever it is, your position is clear, it's cogent, it's comprehensive. By the way, when I present this material to non-Jewish audiences, they're blown away. I talked in a hospital. The Jews get up and say, "Shkoyach, thanks." The non-Jews say, they're like, that's amazing. They had no idea that we have such an incredible, comprehensive, cogent approach to these with consistent principles. They're amazed to hear. They're very respectful usually. They sometimes accuse us of spending too much or doing too much. They never accuse us of being immoral. So we occupy the high moral ground. They respect that. They have to respect it. So you put your position very clearly. You advocate. By the way, you should be advocating not just for Jewish patients. That's not right. We shouldn't be letting... What I said tonight up to now applies completely equally to Jews and non-Jews, the value of life. And therefore, there are rare circumstances where it becomes acrimonious and they call us immoral. I'll give you one example. I was in a big hospital in London. where a young man in our community had been bad head injury, young childless couple, and he was in the ICU there, and he was clearly brainstem dead. I was there during the brainstem criteria testing. He clearly met the criteria. He was clearly brain dead. In British law, that's dead. His wife's sitting next to him. I'm sitting in the room. A couple other doctors and rabbis in the room. The ICU consultant walks in and he says, this patient's dead in British law. We're stopping all treatment. We said to him, look, doctor, that's true in British law, but in Judaism it's not so clear, and we'd very much like to continue treating this patient. His heart's beating spontaneously, etc. He said to us, you Jews are immoral. Because tonight's the 24th of December. Today's 24th. Tonight is the only patient in my ICU. You're asking me to keep my Christian nurses here on their religious holiday for a patient who's dead. That's immoral. So, he wasn't joking. He wasn't joking. He walked over to the wife and he said, lady, your husband's dead, I'm switching off the machine. At that moment, fortunately, the head of ICU walked in. He said to this doctor, what are you doing? These Jews have a right to their religious views. And they kept the machine going, and the heart stopped 6 hours later. You know, you can have those situations. But usually, they're respectful of our position. You advocate correctly. You're balanced about it. You're knowledgeable about it. They can only respect that. Yes?
Two scenarios. Basically, the talk was absolutely superb as always. We get a situation of patients having what's called a living will. And a living will is a difficult document to fulfill. I have many patients in my cardiac practice who give me a living will and say, don't you forget, this is here.
Yeah.
If I'm in that situation, you better obey it. And a very interesting situation a few years ago was a patient and a friend who was a lawyer, and he kept, from every time I saw him, he reminded me of the living will. Don't you forget my living will. He then developed stomach cancer, had a laparotomy, and things went wrong during the anesthetic, and he came out and they couldn't wean him from the ventilator. So he came out and ventilated, his blood pressure fell, he next was on dialysis. I was overseas, I came back that day, I went to see him together with the wife and his rabbi, and he was then awake. And his eyes looked at me and he was very, really angry with me. How do we handle this kind of sin? Because it's this living will to me is a very difficult thing to deal with.
Okay, first of all, you heard the clinical scenario here. Very little could have been done there. It was during an operation where he was on a machine for the anesthetic, right? Nobody put him on the machine in an invalid fashion. So he couldn't blame you for getting him into that situation. Okay, a living will, halachically, I can only tell you halachic position. It's fully acceptable where what they write accords with halachic criteria. Right? For example, let's say they want to accept a brain death standard. So you know that's a vexed issue halachically. There are two opinions about that. In Israel, again, there's a very interesting law. Israeli law accepts brain death criteria with many checks and balances, has to be reported to a Knesset committee. There's a whole much more conditions than in other countries. But the chief rabbinate has, there's in fact an act in Israel called the Brain Death Act, and it accepts a brain death. However, it allows a citizen to opt out of the definition if you don't agree with that definition. So you have an option which standard you want to use in Israel, and it respects the minority or the second opinion as well. If they write a living will that accords with Jewish law, absolutely. If it does not accord with Jewish law, Jewish halacha would say that that's not within their purview to say, switch off the machine while it's actively keeping me alive. Now, legally, you'll be in trouble, because legally you'll be obliged to do what they said, because the law of the land urges you to do that. Halachically, you'll not be allowed to switch off the machine. Brain death's a bit easier, because there are many halachic authorities who say that if the patient is brain dead, even though we might not have opted for that as a standard, where they need the ICU position, you're not going to switch it off, they're going to insist on it, there's virtually no way you can stop it anyway, don't have to be overactive in not allowing them to do that. Yes, please.
Right. So, what happens in, for example, the case where a child sustains significant trauma and they're now technically, they've let out quite a lot, and they have to be, their parents have to be a Jehovah's Witness.
Yeah.
And they inherently blatantly
Yeah.
refuse blood transfusion.
Yeah.
Where that action of giving them blood will bring them out of that. So
Yeah.
it's part of resuscitation.
Right. Well, you've asked an easy question, because you asked about a child. Let me cover this. Again, it isn't only the law of the land, it's also the patient's wish. But the reason that's valid is because autonomy is high in the law and ethic of the land. You probably know that in secular medical ethics, there are 4 criteria that govern, well-accepted criteria, that govern all ethical situations. They are autonomy, that means it's my life, I'll decide what I want with it. Justice, That means, no, you won't when that's unfair to somebody else. Beneficence, I must only do what's for the patient's good. And non-maleficence, you can't do what's for the patient. By the way, we agree with all of those. We just define them differently. Like when they think beneficence means killing them, then sometimes we don't agree with it. But those are the criteria. Since autonomy is very high on the list, and in America it's paramount, okay, therefore if I'm a Jehovah's Witness, I don't want blood, there's nothing you can do. And if you give the patient blood, you're in legal trouble, okay? I was in California at a medical conference some time ago. One of the doctors there told me about a colleague of his who was working in the casualty, what they call the ER. 2 o'clock in the morning, he got a desperately, terminally ill AIDS patient in respiratory failure who he wasn't sure what the patient's wishes were. It was, one of those confused situations. He put the patient on a ventilator. Turned out the patient had clearly said he did not want to be, now being sued in California for assault and wrongful life. If he loses the case, he loses his license to practice medicine. Okay, Jewishly, that's just ridiculous, but that's autonomy. Now, when the person's a Jehovah's Witness, I will not accept blood. So the law of the land will prevent you from giving the person blood. If you do, you'll be sued for assault. When it's a child, so here's the rule. British and American courts, I'm not familiar, maybe the lawyers can tell us in South Africa, I'm not familiar with a case in South Africa, but test cases both in Britain and United States have ruled consistently that when it's a child, you sideline the parents and save the child's life. There are classic precedents in Britain, both with regard to giving blood and things like chemotherapy or proton beam. There are other things as well that parents have been sidelined where there's a clear medical benefit. The language of the law in Britain is this. The state has an interest in the survival of the child that trumps the parent's religious convictions. And therefore, when the parent says it's our religion, we say we don't care about that. You're not entitled to make a death decision for a child. What's not clear in American law and British law is a fetus. I was in Atlanta some time ago. I had to give a presentation on this subject. The head of anesthesia there told me that he had a pregnant lady admitted to his hospital, 3 o'clock in the morning, bleeding desperately. The opinion was that she'd probably survive, but if she didn't have blood, the fetus would die. The lady said, no blood transfusions, I'm a Jehovah's Witness. They said, lady, your baby's going to die. She said, it's God's will. He said he phoned up a judge at 3 o'clock in the morning. He said, I want you to get out of bed and sign me a court order. No one's dying in my operating room. The judge signed a court order. So hospital security held the lady down. They transfused her against their wishes and saved the life of the baby. I don't know what the basic law in South Africa is about that. But when it comes to a fetus, that's a discussion. And there's a legitimate discussion. Is the fetus her life? Is it the fetus's life? That's a legitimate area. But when it comes to an underage child, then the country will force treatment. When it's an adult, there's nothing you can do. And you as a Jewish doctor, you ought to do your best to advocate for the saving of life, but they're very firm about their religious conviction, and basically there's nothing you'll be able to do in those situations.
In answer to that, I had the exact thing years ago, with a child had an accident, exactly what you're saying. I called a magistrate out at 2 o'clock in the morning. In South African law, he signed that I was allowed to transfuse the child. The child survived and left hospital.
What did the parents thank you afterwards?
I'm not sure.
Yeah. Yes.
How do you answer honestly,
Yes.
but without eradicating?
You answer dishonestly. Yeah, let's be clear about this. Somebody's desperately ill. They ask you about their prognosis. Here's the order of business. Is this somebody who really wants to know and can handle it? And there are very well-adjusted, spiritually mature people that you'll be doing them a massive service to tell them. Absolutely. Help them prepare. And then you do it kindly with all the correct stuff, not shockingly. Again, the law of breaking bad news in Judaism is you have to say it in a way that gradually brings them to realize. That's the law. You don't say it. You say things in a way that gradually dawns on them what you are saying. That is a non-shocking, kind way to say the news. So there's a very careful way you do it. But absolutely you tell them. And you give them a positive message, and you help them prepare. If, in your opinion, they're asking you a question that they don't want to hear the wrong answer, or you know that it's going to harm them or shock them, then you have to be very judicious about, again, the truth is subservient in Judaism to the patient's survival. We try, obviously, to be as genuine as possible, and in the long run, it often stands you in good stead to have, right? But, they say that if you tell the truth, you don't have to remember too much. Tell the truth, you don't have to remember too much. Tell lies, you've got to start remembering a lot of things that you said, right? But the patient's life comes before a strict adherence to the truth. Yes?
Yes. About a living will.
Yes.
I don't think, with all respect, Dr. Castle, that you should take on a patient who has a living will if you're not going to abide by it.
Okay.
And I have seen,
Yeah.
over my very long career,
Yeah.
many Jewish doctors torture their patients.
This doesn't sound like a question.
Torture
It doesn't sound like a question. It sounds like an opinion.
I spoke to Rabbi Harris.
Yes.
We started something and then he died, unfortunately. Because what's going on is actually unacceptable. It really is. Now, there was a patient who had lung cancer. He was dying. He was full of fluid in his head, fluid infusions. The hospice nurse, whom I happened to bump into as she came out of the house, was crying. I said, why? She said they insist on giving him a drip because you cannot let a patient die without a drip. She said he's drowning in his own fluid.
Yeah, well, that's medically incompetent, as you know.
No, but they do. These are very well-known, senior, very good men.
But don't blame me. Speak to those good men.
I had a registrar.
Yeah.
There was a patient who had cancer of the esophagus, broke through to the trachea.
Yeah.
He couldn't breathe
Yeah.
at all. He
Yeah.
was dying.
Yeah.
I said to the registrar, give him Dormicum.
Yeah.
It's the only thing you can do. Let him die without. He was going quick. He refused because he's Jewish. Now, what do we do? I can tell you, I'm not going to waste your time with so many. What do we do about those doctors who misunderstand the Torah?
Yes.
And also doctors who will not abide by what the patient wants because they bring their views
Yes.
onto the patient.
Send them to me. Send them to me.
No, Dr. Kessel, you shouldn't have taken that patient.
The point made was that a doctor shouldn't take on a patient appearing to abide by their wishes when he's not going to abide by their wishes. Okay, good point. Don't take the patient. Agreed. Yes.
And there's a big movement, especially with the medical aids,
Yes.
futile care.
Yes.
That they, if at a certain point in a person's life, or there's okay to say 75, we're not going to be paying for
Yeah.
medicine.
Yes.
We're going to generate that because a huge percentage of the money spent goes to those later years in a person's life.
Yeah.
So how would you answer that and say? And then they're saying, well, we're going to give the money to the children.
Right.
So how would you answer?
Okay, what do you do about what's defined as futile care? Age is irrelevant when it comes to futility. That is just completely ridiculous Jewishly. There are some Jewish opinions that in a triage situation, you save the older before the younger, believe it or not. Although it's not the majority opinion. Age, futility is a valid issue. Age as an issue in futility is completely irrelevant Jewishly. Now, there are futility situations where ongoing treatment is actually futile, and that often makes medical sense. Here, there's a discrepancy between what they call futile and what we call futile. Sometimes the hospice moon will call feeding futile, right? And we don't do that. But age is completely irrelevant. Let me ask, yeah.
Is there a point at which one is halachically obliged to stop? I mean, in the situation of terminal illness, basically your family, where the doctors are saying there's no hope, it's a matter of
I did
time.
speak about this maybe before you walked in, that when you fulfill all the criteria that I began with, you're obliged to stop. Absolutely. You're obliged to stop, not permitted to stop, totally. But you need all the criteria that I covered. Let me ask you this.
Question.
Yes.
So,
Yeah.
are you in a good answer still?
No.
I just want to ask you, so to
Yeah.
answer your question, when we get the machines with time clocks, the medical aid will allow them to give an authorization number just for that 24 hours.
Okay, fine.
But separate point. In a situation where you have a patient who's got futility, it looks like futile, so advanced obstructive lung disease, etc., and you put them on a ventilator, now you've got a problem, you need that ventilator.
Yeah.
So there's one thing to withdraw care, but when that patient starts stacking their CO2s,
Yes.
and do you have an option to not change your parameters on your ventilator and in that way allow them to...
It could be. Could be.
Is that how that...
Yes, because you're not doing something. You're not switching it off or turning it down.
So you can stand by and watch those CO2s...
Again, if you fit all the criteria.
Yeah.
Absolutely. Yes. Yes. Can I? Yeah. I'd like to offer you one more small subject if you've got the energy for that. Yeah. Yeah.
What's our obligation if we come past a person that's knocked over or injured, and what is our obligation?
You mean if you don't know they're Jewish or not, or what?
Yeah.
Somebody's injured, you do everything to save them, absolutely, on Shabbos included, regardless of their religion.
And say you're worried about you have no gloves and you're not protected.
Okay, this leads us into another whole area of how much danger do you have to accept to save someone else? with your permission, I'm not going to deal with that. It requires a lengthy, formal discussion. I could not do justice to it now. That's another whole, read my book. The book is stratified into how much risk you can buy the book. You can tell the local bookshop they need to get copies. And if you buy 2 copies, then you'll really understand it. So that's a whole wonderful area. There are limits to, again, there are situations in Jewish law that are so risky you may not put yourself into. There's situations that are so risky that you can, if you want, but you're not obliged to, and the situations that you're obliged to put yourself into. How that works, if you're a professional, there's different standards. Okay, if you're a doctor, you may be obliged to take on more. War situations and army situations have got a completely different set of criteria. I just cannot do just. If you like, we can spend 5 more minutes. Have you got 5 more minutes, Eric?
Yeah.
That wasn't the most enthusiastic response. But what I'd like to do, with your permission, just cover briefly what happens when you can do something that is so risky that if it works, you'll save the patient, but if it doesn't, you'll kill them sooner. Then, okay, this is a terminal illness type situation. We didn't deal with Goseis. That's another whole area. Again, read it up, or I'm happy to send you written material. But let me briefly touch on this area. I'm not going to go into the derivations, how the Talmud gets to this principle, except where it's directly relevant. And that is, what if you have a person who is terminally ill, but there's some procedure or therapy that can be offered to them, which, if it works, will save them, but may kill them tomorrow morning during the procedure. So this is a person who may live for 6 months or 9 months. That fits terminal illness definition in Judaism. Is it better to prepare yourself and say goodbye to your family and wind down? Or is it better to undertake a procedure tomorrow that if it saves you will give you a normal lifespan, but if it fails, will kill you tomorrow morning? You can think of radical chemoablation, and chemotherapy, or marrow ablation, or maybe, major aortic replacement with many, branches at the same time, and the person is desperately ill. I mean, there are many surgical and medical scenarios where we have a procedure that, if it works, will be okay, but if it fails, you'll deprive them of the months they would have had. Okay, that's common. That's common one way or another. So let me be clear about this. First of all, the default position here in Judaism is, if you don't know if you're in that situation or not, do nothing. Let's be clear about this. If you don't know if your intervention will kill or save, rather let them die because you didn't do something than because you killed them. Is that clear? So again, you don't know if they're just holding on and doing nothing, they'll survive. If you touch them, you'll kill them. Or they're dying, and if you intervene, you'll save them. 50-50 either way. You're not improving the patient's chances, right? You're walking down the road, somebody you mentioned, badly injured. You walk up to them. I don't know if people stop at accidents anymore. Do they? They probably don't want to get AIDS. I don't know. In America, they don't want to get sued. In Britain, they're too polite. The point is that here's this person, their neck's at a weird angle, they're gasping. Even a neurosurgeon can be tested in such a situation. Do you put gentle traction on their neck and straighten it out and you'll save their life? Or when you start moving their neck, you kill them? That's a okay. So in such a circumstance, the default position Jewishly is don't touch them. I mean, stabilize them and do the other stuff. Rather, they should die because you didn't save them than because you... Is that clear? Again, there's 50-50 chance either way. All you're doing is swapping a 50% chance that they die because you killed them for a 50% chance that they would have died anyway. So when in doubt, leave it out. Non-interference rather than doing damage. This is an old medical rule that your first concern should not be to do any harm. However, when you're facing inevitable death, that means if you don't intervene, they're for sure going to die. Now we're allowed to take serious risks. So let me spell it out very briefly and we'll finish with this. I'll tell you the derivation because you'll see it has a fascinating, really fascinating halachic application. The Talmud says like this, without the details. There was a case of 4 men who had leprosy. Gehazi and his 3 sons, very wicked people, banished from the Jewish camp. The Jews in Shomron were surrounded by the Aramean army. They were starving. They were being besieged. And 4 Jews had been banished from the camp because they were lepers. In fact, the Talmud says they were so evil, these people have no share in the world to come. They were wandering in the hills, starving to death. So there's a story in Tanakh about these 4 men, and it says, they said to each other, what should we do? Should we wander in the hills till we die of starvation, maybe 3 or 4 days? Or should we enter the enemy camp where there's food? Either they'll summarily execute us as Jews, or maybe they'll give us some bread and take us as slaves. So the dilemma was, do you do nothing and have a guaranteed death? Or do you risk something that might save you in the long term, fully save you, by the way, not extend temporary life? Not talking about extending 6 months to 9 months. We're talking about giving you a complete lease on life, or you may be killed immediately. So there it says in Tanakh, in the Navi, they decided to enter the enemy camp, and as it happens, they survived a whole miraculous story, and those details are not important, but they opted to enter the enemy camp. And from that learns the Talmud, when you're faced with such a dilemma, should you guarantee death in the medium term, or risk short-term death if it gives you a long-term option, we understand that it's acceptable to take the risk. Something very off-key here in this story should bother you. What bothers you about the story? What? No. Of course. Since when do we learn from wicked people? Halachic precedent from evil people? Says Rabbi Moshe Feinstein, as only he could, the Talmud is not telling you a moral principle. It's only telling you what a highly intelligent, ordinary person might decide. And therefore, you may decide. And he rules, and there's no halachic argument about this, we ask the patient, do you want to prepare yourself and die in 6 months' time? Do you want to risk a procedure tomorrow that might save your life? It's up to you. Now, what should the person decide? And if they ask you, Rabbi, doctor, what do you recommend? So it's like this. What are the percentages? If the survival rate of this procedure we're offering them is less than 50%, that means the chances are it will kill them. Here's a very interesting split of opinion. If you look in the older halachic literature, 100 years ago and more, there was a very strong opinion that that would be forbidden. That would be forbidden. That means you have 100% chance of dying in 9 months' time. You've got a 60% chance of being killed tomorrow morning. You may not undertake that procedure. Why? I once asked Rav Moshe Shapiro, one of the great rabbis of this generation. He said a beautiful logic. Because any treatment that is more likely to kill you than save you has no right to be called a medical treatment. That's not medicine. You're allowed to undertake normal medical treatment. Something that's more likely to kill than to save doesn't deserve the name of a therapy, out the question. However, despite that, many other authorities and all the modern halachic authorities rule that even if the survival of the procedure is less than 50%, it's acceptable. You may. So here's how we rule. If the procedure is more likely to save you than not, you ought to undergo it, but no one can force you. You're talking about a 40% mortality. In such situation, we say to the patient, what do you want? Halachically default, we would do that. If it's a child or somebody who cannot opt and we're forced to make a decision, we could well make that decision. They ought to do it, but it's up to them. If the risk of the procedure is greater than 50%, that means the chances are it will kill them. The modern unanimous consensus is even that's acceptable when the alternative is certain death. How small does the chance have to get before it becomes ridiculous? A very wide range of opinions. Ask your local Orthodox rabbi. There are opinions. The Chasam Sofer says 1 in 1,000. 1 in 1,000. You're going to die for sure otherwise. 1 in 1,000. Some say 10%, some say 20%, some say 30%. Rav Yashiv classically said 30%. When the figure gets down to 30% or less than 30%, this is not significant enough to take the option. But if it's 30% or more, yes. Where did he get 30% from? Where did he get? There's no halachic precedent for 30%. 5 to 10%, there's halachic precedents for that. What's called a minority is significant. There's no source for 30%. So they asked Rav Yashiv, how did you come with 30%? He said, as always, we look at the source. What's the source? The 4 lepers wandering in the hills. What was the dilemma? They faced 3 options. Option 1, wander in the hills till you die, death. Enter the enemy camp and be killed, death. Enter the enemy camp and be saved, live. 1 in 3. You see the scenario was a 1 in 3. After survival, it has to be a 1 in 3 chance. Okay, you have to be ready to come up with that source. But this room for judgment, and the bottom line is basically, no matter what the percentage is, you ask the patient. So in Judaism, it's fully acceptable to do something that is highly risky when the alternative is certain death. It requires good medical judgment, good halachic judgment, personal judgment. That's an area. Any final questions before we... Yes?
You have to force a patient who doesn't want to.
Okay, I'm not going to do justice to this either. Up to what degree in Judaism can you coerce someone into treatment? Well, it's clear from what I said that when they are legitimately deciding not to continue, you're absolutely not allowed to, right? If you cover the criteria we said tonight.
What if it's not a...
Okay, if you're in a situation where they're improperly choosing to die, they inappropriately depressed or just uninformed Jewishly, we could save them, they don't want to, etc. They are a Jew who believes in this non-transfusion, all that kind of stuff. Technically speaking, Jewishly, you're obliged to force them to save their life. You're going to be in big trouble legally. If it goes wrong, you're going to be in all kinds of trouble. You may well not be able to do that because of the law preventing you. There may be immense practical obstructions to that. You're also not required to risk your career right? If you're going to go be sued and who knows what. But the basic default assumption is that if somebody's opting to die in a ridiculously inappropriate fashion, Jewishly, you can force them. I'll finish with an answer to your question I think you'll enjoy. And I promise you we'll finish with this. Israel has an amazing law, secular Israel, has an amazing law on the books. This comes out of the Dying Patient Act. The law allows you in Israel to treat a patient against their express refusal. There's no other Western country where you can treat somebody against their refusal of permission, right? Absolutely not. When I was a medical student at Baragwanath, we had a patient with a black 18-year-old Zulu guy from the Ciskei who had a simple hole in the heart that required, didn't have reversal of flow yet. A simple procedure would have closed it, he would have been fine. Left unattended, he'll have a reversal, he'll die within a couple of years, right? Okay, we couldn't get consent because he couldn't understand the issue. He didn't speak English. I remember the old nurse, the old sister in the ward, trying to explain to him like what was going to happen. So he said, okay, tell me. She said, well, these doctors here are going to cut open your chest. Like, he was a Zulu, but he went white. Then they're going to cut open your heart. Yeah, they're going to save my life. The only time he's ever seen that done was they cut out the hearts of people to make their muti. Like, she could not he had no cultural ability to understand that you can cut someone's chest open and he's not going to feel it. And you're going to take his, and he left. All he cried was a thumbprint as consent, and we couldn't get it. He was sent home to die. Because nobody could sign, do you understand? You couldn't sign consent for him without tragedy of South African cultural situation, right? So in Israel, there's a law that under certain narrow conditions, you can force a patient into treatment against their wishes. And I'll tell you what the law is. Provided you cover a number of criteria, you can force them into treatment. Here are the criteria. The patient has to be certainly dying. The procedure has to be certainly life-saving. There must be no alternative. And here comes the interesting one. You must judge that when you do this, the patient will later thank you. Okay. Let me tell you the logic for this. This is not like requiring prophecy. The logic is, if in your best judgment, the patient is refusing treatment for some inappropriate reason, and you know that once they've gone through it, they will clearly agree in the future that it was appropriate, we can reckon that as proactive, retrospective agreement. That was suggested to the Knesset by a very learned rabbi. He put it in legal terms. He said, well, we can assume this is the patient's wish. Why? I know they're refusing now, but we can make a judgment that probably when they're feeling better, they would agree that what they said was inappropriate. Let's take that judgment and not the one they're making now. I'll give you a classic example. In Sharet Tzedek Hospital, they had a 23-year-old girl with terminal cancer. She was expected to live for 9 months, whatever it was. She suddenly developed acute bowel obstruction. She needed an emergency procedure to relieve the obstruction. She refused. She flatly refused surgery. They couldn't get her to agree. The doctors, I know one of them, they invoked this law. They anesthetized her against her wishes. They relieved the obstruction. They saved her life. The next morning, she crawled down to the hospital florist and bought the medical team a big bunch of flowers for saving her life. They said to her, but why did you refuse? She said, I was too ashamed to tell you. I have a phobia of needles. I would rather have died. There are countries where that girl would have died. That's a very appropriate use of the law. You could not use this law to transfuse a Jay's witness. They will not thank you later. They'll say you broke my religion. The law won't help you there. But it'll help you, you understand, it'll help you in a situation where you will think. And sometimes you get completely inappropriate. There was a 75-year-old lady in Tveria who had gangrene of her leg. Flatly refused amputation of the leg. The doctor said to her, but you're going to die. She said, look, I am 75 years old. If you amputate my leg, what's going to happen? I'm going to live for a few more years, and I'm going to die. I do not want to go up to an eternal world and walk around eternally without a leg. I said, lady, that's not the right way to think. She said, don't tell me. I lived with this leg, I'm dying with it. They didn't use the law. She was a Sephardi lady. They got the Israeli chief Sephardi rabbi, Rabbi Mar, to travel to Tveria. He sat at the bedside. He said, lady, I promise you, you have your leg cut off now. It's what Hashem wants. It's the halacha. I promise you'll wake up in the next world, you'll have your leg. She said, Rabbi, that's what you say. I'm signing for surgery. No problem. She signed, amputated her leg. That was just a little halachic misunderstanding. But basically, amazingly, it allows you to coerce a patient when in your best judgment is what they really should have and would have wanted. That's very unique. Okay, thank you very much for